So we're going to talk about fluids. Not all the same. We got to know what we're hanging. So there are different fluid types within our body, right? We have intravascular fluids and extravascular fluids. So our intravascular would be fluids within our blood vessels, okay? So when we have hypovolemia, that's like dehydration, decrease in fluids, decrease in organ perfusion. We can have hypervolemia, which is what's going to result in like our edema, our crackles in our patient's lungs. Right? We have too many fluids that our blood vessels aren't able to hold on to it. Right? They're overstretched. It's able to seep to those epithelial cells. We'll have like that capillary permeability. And then extravascular fluids. So these are also called our interstitial fluids. These are fluids outside of the blood vessels, but not within the cells. Okay, we have intracellular, extracellular. Extracellular is also interstitial. We're not talking the cellular level. This is just in our blood vessels, not in our blood vessels. Okay. When we have a lot of interstitial fluid, that's when we're going to see, again, our extremity edema, our pulmonary edema, our pulmonary infiltrates, right? Fluid on our lungs, all that good stuff. So, fluid balance. So, the way our body manages fluids is in a couple of different ways, right? So, with hydrostatic pressure. So, hydrostatic pressure is the way that fluid shifts from a level of high concentration to a level of low concentration. Hydrostatic pressure is the measurement of like how much pressure fluid exerts on a container. The container in our body is our blood vessels, our capillaries. Okay. When we're hypervolemic, we're going to have that fluid leaking out. High level of hydrostatic pressure is going to stretch our blood vessels, stretch that epithelial layer, okay, making that layer permeable, especially like at our capillaries, and it's going to start seeping through like that capillary leak. When we have a low pressure, I'm going to be hypovolemic, and so our hydrostatic pressure is going to shift, okay, and fluid's going to seep from that interstitial extravascular into our blood vessels. Okay, it's going to pull in fluid and pull in solutes. Fluid also moves through filtration. Okay, this is how our kidneys filtrate our blood through hydrostatic pressure. All right, so when we have an area of a high concentration of solutes, an area of a low concentration of solutes, water is going to move from low to high, filtering it out. That's how our glomerulars work. Another way that our body manages fluids is our RAS system, so our renin-angiotensin-aldosterone system. So when our kidneys feel a decrease in blood pressure, they're going to activate renin. They're going to release renin, which is going to go to the liver, be converted into angiotensin 2, angiotensin 1 from angiotensin 2. Angiotensin 2 is going to constrict, and then we're also going to have a release of aldosterone from the adrenals. And aldosterone is going to retain sodium in fluid. Our body also manages fluid by like making us thirsty, right? It's normal to drink about 2,500 mils a day and excrete about 2,500 mils a day, depending on what you're doing. This is all controlled by our hypothalamus. So our antidiuretic hormone is released by our hypothalamus in a response to the osmolarity of our blood. So if we have a high osmolarity, it's going to release antidiuretic hormone to hold on to more fluid, right, to decrease the osmolarity. So decrease the amount of solutes in our bloodstream comparatively to fluid. So fluid replacement. So this is going to be fluid replacement that we're doing, okay? Not your patient drinking more water, not their RAS system working, not their hypothalamus releasing ADH. This is fluid replacement that we're doing. Okay, we have fluid types. We have hypotonic, which is going to be an osmolarity that's less than 0.9% normal saline. Okay, so this is our half normal saline. This is our 0.3% normal saline. 0.3, not 3%, 0.3% normal saline. Distilled water, our hypotonic solution, so not very salty. Then we have our isotonic solutions, which has an osmolarity equal or about similar to plasma. So our normal saline, our 0.9 NS. Our lactated ringers, okay, a normal or an equal osmolarity to our blood. Then we have hypertonic saline, or hypertonic solution, which is going to have a high osmolarity. So this is like our D10, our D5s, our hypertonic saline, okay, our 3% saline. Then we also have blood products. So blood can come in many different ways. Whole blood, which is going to have everything in it. Packed red blood cells, platelets, and fresh frozen plasma, which we will talk about. Some things that we want to check out before we're doing fluid replacement, right? Why are we replacing it and why are we using this type of solution? What are their labs? What does their skin look like? Do they have skin turgor? Do they have dry mucous membranes? What do their lungs sound like? Do they have crackles? Okay, should we be giving them fluids if they have crackles? Probably not. What are their heart sounds? Okay, hypervolemia can cause a heart murmur, all right? If our patient is so full of fluid and their heart is so stretched, those valves won't be able to close. Do they have edema? Do they have edema just in their feet? Is it in their ankles? Is it all the way up their legs? Okay, let's look at our patient. Are they drinking water on their own? Do they really need these fluids? Take a peek at our patients. So hypotonic solutions, again, osmolarity lower than normal saline, so lower than 0.9 NS. This is like our 0.45 NS, our 0.33 NS, 2.5 dextrose in water, distilled water, 0.25% normal saline, which sometimes we'll use with like little nuggets. Fewer solutes than plasma. So when we have fewer solutes in the plasma, we are going to kind of water down our plasma, if we think about it that way. And then we could have a fluid shift from our intravascular to our extravascular, because our extravascular has more solutes, less water than the fluid that we're giving. All right, our goal of this is generally to correct our fluid balance without disrupting the solutes too much. So when we have hypovolemia with hypernatremia, we don't want to give them a lot of sodium. Okay, so we're going to use our 0.45 NS. Sometimes you'll see like half NS D5. That is an isotonic solution. That D5 increases the osmolarity, so it's not hypotonic. Okay, they're not all the same. Hypotonic solutions can cause hyponatremia because, again, we're kind of diluting the solutes in the blood. Okay, we're going to bring down those solutes. So our solutes are all of our electrolytes, our albumin, our glucose. Okay, we can make all of those lower in concentration. Beautiful. So, beautiful. Okay. So again, nursing consideration. So this can exacerbate our hypovolemia. Okay, because we can have a shift of fluids from the low solutes to the high solutes. So if we dilute too much intravascularly, we can have a shift of fluid into that interstitial space. So we don't want to be using hypotonic solutions in our traumas, burns, or for hypotension. This is mostly for our stable fluid replacement when they already have high electrolytes. Again, monitor for that fluid volume deficit, right? Are they thirsty? What's their urine output? What does their urine look like? What are their lab values? Okay, we're going to want to watch that sodium, potassium, magnesium. What are we doing? We cannot give this with blood products. Okay, and we'll talk more about blood products towards the end of this presentation. Hypotonic solutions can also cause like a swelling of our red blood cells, right? Our red blood cells don't have a ton of water in them, and so when they're in a space that is diluted, right, has a ton of water in it, that water's going to shift from a low to a high, okay, from a low concentration of solutes to a high concentration of solutes within the red blood cells. It can actually cause hemolysis of the red blood cells, all right? So what is their hemoglobin? Okay, does it look like they have blood in their urine, which is a sign of hemolysis? And it can also cause an increase in intracranial pressure, okay, because we have a risk of hyponatremia, a risk of that fluid shifting into the interstitial space, which you don't have a lot of room in your brain for extra fluid, right? Watch their neurofunction. Check on these patients. They should not be on a hypotonic solution for very long. So our isotonic solutions. Our isotonic solutions have a similar osmolarity to plasma. If you ever cut your finger and like licked it, right? Blood's salty. These are salty. This is like your 0.9 NS, lactated ringers, D5 in water, LR with D5 in water, our half NS with D5. Okay, these are our isotonic solutions. This is used for fluid replacement or maintenance. Isotonic solutions cannot carry oxygen. Okay, so if somebody is bleeding, we need to replace their blood loss. If somebody's diuresed, we need to improve their hydration status. Or, for example, diarrhea, right? Then we need to replace that fluid loss. What else do I got here? D5W is nice to use too for our patients who aren't taking a lot in oral leaks. It has a little bit of like a caloric support. LRD5 is helpful with like a metabolic acidosis, okay, because it's gonna also has a little bit of and when we give, our D5W, that's mostly again for caloric support, not necessarily great for rehydration. So nursing considerations when we are giving isotonic fluids, right? Check, why do they need them? What do they sound like? Assess your patient. Are we overloading them? If we're overloading them, can we stop these fluids? Please, please, please. What are their vitals? Okay. Sometimes with fluid volume overload, we can also see a tachycardia, maybe a hypertension. Okay. Are they needing more oxygen? That's generally like a really good indicator. They have too much fluid on board. What's their respiratory rate? Elevate their head of the bed if you think we're doing too much fluids, right? Get that fluid off their chest if we need to. Things like LR. So LR has all of the other electrolytes that NS doesn't. So NS is normal saline. It's sodium, chloride, and some fluids. LR's got 130 of sodium, which is about what our plasma is, 4 potassium, 3 of calcium, 109 of chloride, and it's got lactate in it. Okay, so lactate's going to provide a little bit of an energy source, but we don't want to use it for our patients who already have like a lactic acidosis, because we're going to increase that lactate and we're going to worsen their acidosis. And we also don't want to use it with patients who have liver disease because they can't break that lactate down as well. So somebody comes in, they're hypotensive because they have really bad cirrhosis maybe, hypotensive because they have really bad cirrhosis, we're going to want to maybe look at like NS instead of our LR. So we have our hypertonic solutions. So hypertonic solutions are super, super salty, okay, and really salty things we don't want to spend a lot of time with. So we don't want to use hypertonic solutions often because they're not for fluid rehydration, okay. We're going to be using them more to pull fluid into the intravascular space. All right, it's going to cause our cells themselves to shrink. All right, it's going to cause our red blood cells to shrink. It's going to cause our cells outside of our vessels to shrink. We generally use them for patients who have like edema. So this is going to be our hypertonic saline, our volume expanders, which is like albumin, which is just a really thick protein. And then our hypertonic dextrose, so D10, D20, D50. So you'll see like amps of D50. Okay, that's a hypertonic solution because it's just sugar water. We're using that to help provide calories for our patient. We're not using it to rehydrate them. Right, we're using hypertonic saline to help prevent cerebral edema. Right, when our patient's edema is so bad in their head, we have to decrease it. Or if they're very hyponatremic, so less than 125, is when we can give that 3% saline. And we give it really, really slow. Again, we talked about how 4 to 6 millicues in a day. Okay, so these are dangerous medications. Albumin we can give in a peripheral IV, but our hypertonic saline and dextrose, those need to be given in a central line. It's a tuner's checkoff because if we cause those cells to shrink, right, we're shrinking brain cells, we're shrinking our nerve cells. We can cause demyelination of our nervous system with some of these medications. We can give D10 again for our caloric replacements. Okay, it's 100 grams per liter of glucose, so that's about what our blood is. Very thick, though. We don't just give it as an IV. Right, we're going to carefully be given this. So if we think of like D50, for example, is 5 times the concentration of our body's normal glucose. Okay, that's why it comes in like those little tiny amps. 1 amp is 25 milligrams in 50 mils, right? D10 is that concentration that's normal, kind of normal to what our body's normal glucose level is. So again, nursing implications for hypertonic saline. We want to be using a central line. Okay, monitor for hypervolemia. So we're going to be pulling fluids into our vascular space. Increased blood pressure, okay? Increased heart rate. Verify our nursing orders, right? This is a tuner's checkoff with these, especially for like our hypertonic solutions mostly. Why are we giving this? Are we giving this at the correct rate? What are our vitals before? What's our neurostatus before? Again, high acuity patients, if they are on a drip, if they are constantly getting these medications, hourly neuro checks, because we can worsen our cerebral edema. Actually, if we're giving this incorrectly, if we correct that sodium too quickly. So next we talk about blood products. So blood products, we have whole blood. Whole blood can then be separated into a whole bunch of different things. We give patients packed red blood cells, platelets, fresh frozen plasma, and then we're also going to talk about cryoprecipitate, or just cryo. Nowhere in Montana carries whole blood. You'll mostly see this in like big trauma centers. Generally it's just for like trauma and surgeries because it has all of the things in it. So if somebody is stabbed in the park and they're bleeding, we want to replace what they're bleeding, which they bleed everything. They don't just bleed parts of their blood. So ideally we get whole blood. It doesn't have a very long shelf life, which is why we don't use it here in Montana. We just don't have enough traumas. When we give blood products, it has to have consent. Okay, you have to say, hey, is it okay if I give you a blood product? Things work a little differently in like emergent trauma situations, but you always need consent first, all right? Patients will be type and crossed, so we'll check them for their blood typing, A, B, or O, or AB. And then also they have an antigen response. So that's our AB pause, A pause, B pause, O pause patients. And then go from there. So we are only trying to give them compatible blood products so we don't get some sort of hemolytic reaction. So in whole blood carries everything. Great for trauma and hemorrhage. Again, shelf life about a month. So isn't ideal for Montana, where we often have blood sit on the shelves for a little bit longer than that. And when we can separate out these products, some of these products can be on the shelf for over a year. Let's platelets are going to be kind of colorless or yellow. They have a very short shelf life of only about 5 days. These are going to be used when we have like low platelet counts, so low, it's like thrombocytopenia, generally less than 100,000. But look at your patients, right? Do they have purpura? Do they have bruising? Do they have petechia? Do they have little bruising on their skin? We can give it prophylactically, especially for those patients who are thrombocytopenic, so less than 100,000 and they need surgery. We can give them some platelets, or they need a central line, or they're going to have a baby. We can give them some platelets to kind of pump them up before they're going to have this event that's going to cause some bleeding. Platelets need special tubing. Generally, the tubing comes with them from the blood bank. You cannot use regular blood tubing on platelets. The filter will actually break them apart, and then now you just gave your patient kind of like a bolus of nothing. Only can be given with normal saline. Again, shelf life of about 5 days, and they need to constantly be aggregated, right? When blood sits, it clots. Well, it clots because it's sitting because of the platelets. When platelets sit, they clot, which is why if you've ever been to the blood bank, it's on that little shelf that moves. And so if you're going to give your platelets, right, as you're walking them up to the room, we should be kind of gently aggregating them so they're not sticking together in there. And also we should not be giving them through IV tubing either, right? Platelets come with their own special platelet tubing. Plasma. So plasma is wonderful because it's got all the juicy bits in it, okay? It's going to have all of our clotting factors, so fibrinogen, platelets, and our coags. Okay? It has all of our factors that we need for our clotting cascade. It also has this albumin, so it's a volume expander. So our patients who are maybe a little hypotensive, hypovolemic, and have some coagulopathies going on, so if there's like cancer patients, for example, plasma is wonderful because we're going to replace pretty much everything besides the red blood cells. It needs to be thawed, right? It comes frozen. We don't give it frozen, and we can't just like microwave it and thaw it out. It takes about an hour, if not longer, to thaw it. So if we have a patient who's looking kind of puny, they're showing signs that they might be bleeding, maybe we can talk with the doc about getting some plasma ordered and start that process. Plasma is great because it's going to clog the hole, right? So if we have somebody who's hemorrhaging or they're bleeding, we want to give our plasma first, then our platelets, then our blood. Otherwise, we're dumping all of our blood into a bucket that still has a hole in it. Okay, we want to clot off that hole with our plasma. 24-hour shelf life once it's thawed. So that's why we want to kind of be planning if we're going to be giving it. But it can sit up to a year frozen, which is kind of nice. Has a pretty long shelf life. So albumin is a blood protein. It's a really big molecule. What I like about big molecules is water also likes them, right? It's a big solute, so it's going to pull water from our extravascular space into our intravascular space. That's why it's a volume expander. So we use it in hypovolemia. We'll use it in obviously hypoalbuminemia when we have low albumin, but it's great in like ARDS, like acute respiratory distress syndrome, because it's going to help pull fluid out of our lungs and back into our intravascular space. Okay, sometimes patients who have like congestive heart failure, we can give them some albumin because it's going to pull that fluid off that extravascular space, like in their legs, put it in our blood vessels, and then we can give them some Lasix and help get rid of that extra fluid. We'll use it for patients when we're going to give them like a paracentesis, because in a paracentesis, right, we're going to pull all that fluid off their abdomen, and their abdomen's going to want to fill back with fluid from their blood vessels. We don't want that to happen to cause hypotension. So we'll give this albumin, do our paracentesis, and the albumin's going to help keep that fluid nice and inside our intravascular space. Again, it's also great for burns, because again, burns are going to have that edema, but we're going to have all that swelling, again, extravascularly. We want our blood volume to be nice and plump, and we can use it for hemodialysis too, right? Pull any fluid back into the intravascular and then dialyze it off, so it's not just sitting in their periphery or sitting in their lungs or extra fluid sitting on their heart. Albumin is also calcium binding. So when we have patients who have a low albumin, it might look like they have a high calcium. So whenever we do a calcium check, we need to correct it based on their albumin level. We're going to talk about cryoprecipitate. So cryo has all of our clotting factors. Okay, so we might have a patient who has a normal platelet count, but they're still showing some weird bleeding. Okay, they might just have a coagulopathy. They use this a lot prior to like elective surgeries too. Like they'll give patients sometimes this factor, they can give factor 8 or they'll give them cryo just to help prevent that complication of bleeding. Okay, so it's going to have our fibrinogen, our factor 8, and our factor 13 all within it. It's a nice way to help replenish those factors without giving them a whole lot of fluid volume. There's usually only about 25 to 50 mils in a bag of cryo compared to like a bag of plasma, which is about 500 mils. And then lastly, we're going to talk about our packed red blood cells. Okay, so they're just that. They're just the red blood cells. There's nothing else in there that's a blood product. There's about 15 million blood transfusions annually. So every time you donate blood, you're providing for 3 of those. So we need 5 million people to donate every year. Used to treat anemia is used to treat hemorrhage, right? It's going to improve oxygen delivery. Red blood cells contain hemoglobin, which is what we need to carry oxygen. So if we're bleeding and we're hypovolemic and we just get patients NS, we're not replenishing that ability to carry oxygen necessarily. Looking at a patient like generally like less than 10, less than 8 is about when we want to think about transfusion. But check your patient, right? Are they needing oxygen? Are they showing signs of shortness of breath? Are they showing signs of hypoxia? If not, then they might not need those packed cells just yet. Their shelf life is about 21 to 49 days. The problem with red blood cells is the preservatives in their deplete your calcium levels. So if we have patients that we're giving a lot of red blood cells to, so for example, in a trauma situation or DIC or obstetrics, when we're doing like those mass transfusions of blood products, we also need to watch their calcium level and make sure that we're replenishing that as needed so we don't cause hypocalcemia and cause them some cardiac events. So, complications of blood transfusions. These can be from any blood product, can give us a complication. We generally see it in those packed red blood cells because those red blood cells can carry those antibodies, but we can see it in any product. Okay, so infections, right? The blood was contaminated. We contaminated it as we were giving it. An immune response, so a TRAIL, which is a transfusion-related acute lung injury. It's not a trail, it's a trolley. I autocorrect, a trolley. Transfusion-related acute lung injury. So this is when we have like flash pulmonary edema related to this blood transfusion, right? Our body reacts to the foreign blood products, right? We have an increase in fluid already because the blood it's fluid. We're going to have flash pulmonary edema. Graft-versus-host disease, just like you can have with like any sort of transplant, right? We're transplanting blood. If we don't have the correct type and cross, we can have this graft-versus-host disease, and it's not great for your body to develop antibodies and start attacking your blood system. Or a hemolytic reaction, where the preservative that is in the red blood cells to help prolong that shelf life actually start breaking them down, and they're going to start breaking down our healthy red blood cells within our body too. That citrate toxicity, which is going to deplete our calcium levels, again, hypocalcemia, hypomagnesemia, hyperkalemia, especially if we have hemolysis. Our red blood cells contain a ton of potassium. So if we're breaking those down because of a hemolytic reaction, we're going to have hypercalcemia. And then a trim. So a trim is what happens when we have multiple transfusions. So a lot of our patients who have like leukemias or other blood cancers who need a ton of blood transfusions throughout their lifetime, not just at once. So each blood transfusion, they start to develop a few antibodies to foreign blood. So then at one point, when we give them a blood product, they're going to have that, like a graft versus host disease or some sort of rejection, but then they're also start rejecting their own blood. These patients require irradiated, so they will literally like radiate the packed cells to destroy any antibodies that could be living in them. And it requires a lot of planning ahead for when these patients come in. So nursing implications, right? So we want to assess our patients. When we are giving blood products, we are checking their vitals every 5 minutes for 15 minutes, and then every 15 minutes after that until the transfusion is done. Each product takes a different amount of time. The max is 4 hours per product. Okay, that is how long your blood tubing is good for, is only 4 hours. You cannot switch out your tubing and finish a product, right? So blood products have to be done within 4 hours. When we assess our patients, I check them first, check their temperature, listen to their heart sounds, and listen to their lung sounds. Okay, we can hear some crackles long before we actually see like that pulmonary edema. Patients have hemolytic reactions. They're going to complain of like flank pain, okay? Because when we have hemolysis, our kidneys are having to work double time to break down and get rid of those destroyed red blood cells. Our tubing, so each product requires kind of a different type of tubing. There's blood tubing that has a filter on it to help filtrate out if there's any impurities. Again, that tubing is good for about 4 hours. Your facility will have a policy regarding blood tubing and when it needs to be changed. All blood products are only compatible with NS. You cannot run them with anything else, and you cannot run them at the same time together. Even in like a mass transfusion, you are giving one product at a time. Because if we have a reaction, we need to stop our transfusion, get rid of all of that tubing, restart everything, and then there's a couple things we need to do as well for our patients. Because I've actually seen patients die from trolleys, if they've died from these reactions. Again, vitals every 15 minutes, including a temp every 5 for the first 5 minutes. Okay, a hemolytic reaction can develop a fever first. So if we can sense that fever, turn off the infusion and start treating them with Benadryl, Pepcid, Tylenol, and generally like a steroid to like an allergic reaction. Listen to our lung sounds, right? Assess our IV site. We don't want to start giving them blood and then our IV go bad and then us try to get a new IV. Takes longer than half an hour, which you have about half an hour, again, based on your facility and their policy to start the blood. Otherwise, you have to throw that whole unit away and start over again. And it needs to be a 20 gauge or larger. Okay, those smaller gauges are too small sometimes for the red blood cells and can actually break them apart. And so again, we're giving our patients a bolus of a product that isn't actually going to be doing them any good. Documenting, and then it is a 2-nurse verification. So we will verify with another registered nurse or an LPN, hey, this is my patient, this is their blood type, this is their band. We go through all of the patient identifiers, compare them to the blood product that we're given to make sure that we're giving them the right type, so we're not going to, again, cause any of those hemolytic reactions. So know your policy if your patient has a reaction. Okay, generally it's going to be to stop the infusion. Okay, they're complaining of shortness of breath, they have a fever, they're having back pain, they develop a rash. Stop the infusion. Keep that IV site open by just running NS TKO. Let the doctor know, and then be prepared to either administer something like Lasix, Benadryl, steroids, Pepcid, all that good stuff. And that is blood products and fluids that we will see this semester. Any questions, you guys let me know.